that has been gathered separately to provide a report out to you today. So we will be looking at financial risk across different provider types, and Javion will be presenting that again. Rita Sharma, Chief Operating Officer. Thank you very much, Rita. And you're the last thing between us and the networking gala, so don't worry about that.
I love being the last one between us and cocktails. One, thank you very much for having me and having us here. I'm supposed to talk about financial risk, and you know, there's not a lot of ways to talk about that in a very happy way, because it's financial risk, and it's risk to a hospital, risk to payers, risk to the industry, and it's how to avoid that risk. So the way we'll talk about this is in a couple of different ways. We'll look at it at a macro level, we'll look at it at a provider level, and we'll try to mix all of that together to have some semblance of, after we admire the problem, what are we going to kind of do about it? So with that, we'll kind of get started. With respect to the risk at a provider level, I think we've examined this, and we've had the opportunity now to work with tons of different clients on it. So I think our perspective comes with experience. It comes with reality of seeing what we've done with respect to the data that we've gathered through Financial Risk Calculator and other programs that we've been associated with. So the presentation of that is going to be in a segment of how do we look at it, how do we measure it, and what do we do about it. So those are kind of the themes that we'll have through this session. Starting off a little bit with Javion and what we do, the Bonobo Big Data platform that we've kind of coined now in the industry. We've been able to analyze over 20 million claims that we've done across a whole variety of different provider types. That's from large hospital facilities, small critical access, and even payers. We've looked at this and we've taken this through our platform that we've built, and what that platform does is essentially simulate every single permutation and combination of what would happen at an encounter level between 9 and 10, and then aggregate that back to what it means. So what do you do about it? Aggregate that back to where do I have risk? Why do I have risk? What do I need to do about it? And what are the actions around it? So that piece of our ICD-10 set, basically, or ICD-10 complete module, is where the focus here is going to be. Some of the findings that we've had in the industry, in the calculator, and in other places, are what's going to kind of drive the rest of the discussion on the findings that we've got. I think the best way to look at how to measure this risk, and I've heard just lots of different variations of how to approach it, how to approach the program, some of them conflicting, so kind of confusing as well. I think as we sit here today, and as I was sitting here today, but I think the biggest reason for that is it's a little tricky. You've got one side of the equation where providers today are already having issues with denials, with reimbursement, with AR days, etc., and that becoming magnified with ICD-10, not minimized, is a reality, right? So that's kind of one side of the equation, and that's kind of industry-wide, right? That's something that's very much at a macro level. And then you've got an individual hospital, an organization, multiple facilities, one facility, whatever that may be, and those guys have their own current processes. You've got your own current, coding practices, your own case mix, and the case mix makes a big difference. You also have your own payer contracts where terms and reimbursement, whether they're carve-outs or DRG-based reimbursements or CPT, HIPAA, lots and lots of variability at practice level, provider level, rural hospital. So those variables come in very much at an individual hospital, and you weigh that against what's going on in the industry. So the answer of it depends kind of becomes a reality at a facility level, and so how you measure that risk, you look at both sides of the equation. You don't look at one, right? And you put those things together. You look at what's meaningful to you as an organization, you as a hospital, and you as a group of hospitals or a group of facilities, and you weigh that risk against each other. I like this slide because I like numbers. This is taken from Truman. This is a little bit of history, and we're going to start by looking at the macro industry. From a macro level, we've seen operating revenue. So revenue, what that translates to is everything above a certain line on an income statement, right? That operating revenue we've seen over the last 5 or 6 years be fairly consistent. What does that mean? That means I'm able to fairly accurately as a hospital or as an organization predict my revenues and my costs associated with bringing those revenues in. So everything below that line accounts for my total net revenues. Now this is just an ICD-9. We're just talking historical data at this point. That's been extremely volatile. That red line represents your actual total net revenue. So lots and lots of reasons for that. You've had recession over the last 7 years. You've had issues with respect to lots and lots of change already being introduced to hospitals. And things that account for this bottom line or below the line type of revenue spend is SG&A costs, collection costs, internal processes, IT in most cases falls below that line. Lots and lots of volatility with respect to new implementations potentially, and lots of times we look at this and we say, wow, how are we surviving as hospitals? How are we not able to predict, even though we're able to predict our revenues, not able to predict our net revenues, and why are they so volatile? This is an I-9, and what do you think is going to happen to both of those lines in I-10? Up or down? Probably down. So, from a, what's going to happen and what does it mean to a hospital? It's looking at this as something that's, not good, is kind of a common phenomenon that we say. We hear it all the time. Oh my goodness, it's just a lot of transition, and the risk has helps it none, right? It shows that with both of these operating revenues and total net, you're going to have increased issues with respect to those. So we've got some numbers here on stuff that we've seen with Medicare data, but I think the focus shouldn't be on what is my net revenue reimbursement impact going to be. It's going to be where do I have risk and what do I do about that risk, and that's all we can do, right? We can just make sure that we're addressing as much of the risk as possible. And the first thing you need to do in order to address risk is know what it is, and know what it is at a level that you can do something about it. I think those two things essentially make up why it's so important to know your risk up front when you're doing these programs. Right? And we can't stress that enough. I mean, we've now been working with more than 50 hospitals across the industry, and every single theme that we've seen every single time is different. It's a little bit tailored because of case mix, maybe location, maybe carve-outs, maybe different ways of reimbursement, but what they do about that risk is the most important thing. I'm going real quickly here, so I'm trying to get you guys to cocktails. Again, individual stuff we talked about, case risk, proportion of Medicare versus non-Medicare, effectiveness of your current processes, but at a macro level, again, to bring that stuff in. And this is a study done by, I think it's another Truman study, but any other time, any given period of time, you can see that a hospital is between 20 and 30% of hospitals are running at a loss. That number is in the world today, as it exists today. That's an industry number. I think everybody sort of knows that. I think that from a hospital perspective, that's a real important thing to know. That's not going to get better because of I-10 immediately. So knowing it just compounds the reason of why you need to know where your risks are. Location is another place where you have higher healthcare spend, a little bit more insulated from the actual risk, but where you have lower spend, you've got more risk. Location we've seen be a very, very big factor with respect to financial risk. And I think the third one is, and we talked about teaching hospitals here, but just the type of hospital you are. We've seen large teaching institutes have generally operating in less operating margins and total net margins than anybody else, probably because of case mix and complexity of cases and large spends in R&D. But they are also the type of hospital you are, I guess, is the point. Determines where you've got more risk as well. So we've had several hundred surveys empowering the risk calculator and the self-assessment tool on HIMSS, and some of the outcomes, and this is taken from one of the studies that we did, in that, with that risk calculator. This is the outcome slide. This is essentially, what we've seen from those outcomes, right? We've derived those into, 5 bullets, which are, 1, resources, impacts on resources. Already stretched resources are going to continue to get overstretched. So, from a planning perspective for that's absolutely something that people are aware of. And it's something that's even more magnified when we see the survey results of these things. And this survey and this self-assessment tool, if you haven't done it, it's several questions, probably about 50 or 60 questions that take you through a process and give you a relative financial risk. It's available on HIMSS and it's out there. So take advantage of it. But this is these are just data findings from that calculator. Lack of visibility already, that we have from a coder productivity perspective, and also from a vendor readiness perspective, right? So, how ready are my vendors? That anxiety and that reality, actually match up. That's true, and it's something that that's real, that everybody's seeing. It's a perception, and it is reality. We already have this fear of low documentation, adherence to documentation standard by physicians. How do you get physician engagement in order to run change management programs? What do you do about that? I think the answer to this is really around having strong change management, but coming to the table with, here's why you need to do this additional documentation. It's going to cost the hospital X amount of dollars, and here's exactly what, where you need to make adjustments from it. Revenue cycles need to be revisited. Revenue cycle processes need to be revisited. That's an essential part of this. I think that we've seen that happen in a couple of places that they're already doing, optimization work and everything in that, but we've seen that also in the calculator be something that we've seen as a reality that some people have to look at. And denial rates, the increase of sort of denial rates, I think are something that people are getting aware of. People are understanding, and you need to do something about it. That's the main focus here is knowing what it is and mitigating. So now that we've kind of admired the problem, what can we do about it? I think the financial risk assessment, having lots and lots of parts of this program are absolutely critical, right? You've got to do training, you've got to do physician education, you've got to do IT remediation. All of those pieces of the program add up to dollars that a hospital has to invest, or any organization has to invest to get that work done. Prioritizing those dollars in a way that